very, very promising. It's like it's more, we find more cancer than we had kind of thought or imagined that we would.
Hello and welcome. The following is a conversation with Fredrik Strand, Professor of Radiology at the Karolinska University Hospital. Through his research, Fredrik works with the applications of AI in mammography and detection of breast cancer, and he is one of the leading scientists in his field. Breast cancer is the cause of death for over 600,000 women every year, and it is therefore that attempts like that of Fredrik and his team is an inspiring glimpse of the potential benefits of AI for society and humanity. I was deeply honored that he agreed to participate in this conversation. I am Avid Fayaz, and this is the AI Pod. I hope that you enjoy the program. What is cancer, and more specifically, what is breast cancer, and what are the causes of it?
Oh, that's a very good and big question. So I think basically cancer is when some cells in the body get certain mutations that makes them proliferate and also not respect the surrounding tissue. So it invades the surrounding tissue. And after a while, it can also spread to other parts of the body. So it does not only extend and enlarge where it is, but it can also, cells can it can lose cells that can go into the lymph system or the blood flow and be implanted in other parts of the body. And one little bit scary thing is that those cells are sometimes not detected. So even sometimes when you do surgery to remove it locally, there could still be some cells that can cause like metastasis years later. So it's a very kind of scary disease from that perspective, but it's also something that we have become much better at treating. So if you get breast cancer today, it's a totally different thing than if you got breast cancer 30 years ago. So the what have we improved mainly is the early detection, because I mean it doesn't spread, the first cell does not metastasize, but at some point it does. I mean it could at least. And then so early detection, to detect it as early as possible, is important, and also to perform more precise surgery. And for that they also need radiology to kind of delineate where is the tumor, if they do not remove the whole breast, as was more common before. But now the surgery has become more precise, performing partial mastectomy or lumpectomy, and then they need more precise diagnostics as well to know where it is. And after surgery, normally you get radiation and you get medical treatment and so on, and all of these different steps have been improved and kind of work together. So cancers that are detected earlier are also easier to treat, and the treatment itself has improved and so on. So that's kind of why the situation is a lot better now, but it's not it's far from perfect. So I think it's about, let's say, 20% of the women that are diagnosed with breast cancer will finally also die of breast cancer. It can take a short time or a long time.
And how important is early detection in preventing such things as you mentioned, metastasis and all the other consequences that follow?
Yeah, so two of the most important prognostic factors, and that means like, yeah, how long will the patient survive, basically, are the size of the tumor and if it has spread to the lymph nodes. And of course, the size is related to early detection because the cancer does not like shrink of itself unless it's like super small and the immune system handles it. But when it has reached a like detectable size or a like microscopic size, it grows. So the earlier you detect it, the smaller it will be. And also at some point, it might spread to the lymph nodes, and it does not go back from that. Once it has spread, it has spread. So that's also why it's important to detect cancer early. But it's not the case that there is a certain size where it always metastasizes. So a small cancer can already have metastasized, a larger one maybe not. But as a general rule, I mean, it's related to size also, but they're two independent factors, and both are, you can improve both of factors by early detection.
What are the current methods of detection that are used in, let's say, Western countries such as Sweden?
Yeah, I mean, basically it's either screening, which means that the woman has no symptoms, or it's referrals, because a woman has a symptom and goes to the GP or vårdcentral, or a surgeon or gynecologist, or some kind of doctor that is not a radiologist, and then tells about the symptoms, and we get a referral from that doctor. And that's about half of the cancers are detected that way, that they become symptomatic. And the symptom is most of the time a lump. Could also be discharge from the nipple that is bloody or clear fluid, and some other symptoms basically. And the other 50%, they are detected through the screening program. I think it's about 70-75% of women that attend screening in Sweden, and they are invited every 2 years between the age of 40 and 74, and about 70% of their breast cancer is detected at screening, and 30% is not. So even if you attend screening, you have 30% of the cancer is not detected at screening. So that's something that could be improved, and it's kind of the limit of the method that we use, the screening mammography. It is very good. It has improved like the survival, decreased the mortality, but still it's like we miss 30%. It's not it, and it sometimes it can be that people are human and you miss something that you shouldn't have missed because of some distraction or something. Sometimes there is just a subtle sign in the image that you couldn't really categorize it as something you missed, because it's only in hindsight that you would say, yeah, that was the cancer, because now you know where it's located, and then you can kind of distinguish those signs in the previous image. And then there are the cases where there is nothing. Even if you know where it is now, when you look back on the previous image, there is nothing. There's like no sign of it. So those 30% are like, of these different categories. And sometimes when you say, there is no sign of it in the previous image, sometimes you feel certain that it's like there is nothing, because it's mainly fat in the breast, and the tumor is like have higher density than fat, so it has a high contrast to fat, a cancer in the breast. But if you look at the same spot in the previous image and you see a lot of denser tissue with higher density, like the fibroglandular tissue, the tissue that is the connective tissue of the breast, and also the epithelial or glandular tissue that is potentially milk producing and transporting milk and so on, that type of tissue has a similar density to tumor. So if you have a lot of that dense tissue in the area, you might not see this tumor in the previous image, but it could still be there in the breast in a size that could have been detectable, but it's just not, the X-ray doesn't allow the delineation, because there is no contrast compared to the surrounding tissue.
So there are two elements that might lead to cancer not being detected. One of them is the methods that are used, and the other is errors, by human errors, basically by practitioners.
Yeah.
And on the side of entering into artificial intelligence, how can artificial intelligence be applied to this problem so as to improve the results?
Yeah. So I think, one definite advantage of software is that it is more consistent. It does not, get tired. It doesn't have Monday mornings. It doesn't those kind of things. So that's something that it will kind of even out those kind of fluctuations in human performance. And in screening, we are always 2 radiologists that review each exam. So even if one might miss something, the other one could catch it. But on the other hand, if you have, and another thing that is different between people is not only that you might, lose your attention for some seconds or whatever, but it's also the level of your when do you become suspicious? How obvious must the sign be before you feel that this is something that we should move forward with to discuss if this could be cancer? Because in medicine, we like to categorize. We don't like, it's hard to work with. At some point, we need to have categories because we need to make a decision. We cannot examine a woman to 70% or so. I mean, we have to either recall her for further examinations or not recall her. So it's like a binary decision. And first, 2 radiologists review the images, and if any of them find something suspicious, then 2 radiologists discuss together in a consensus discussion to decide whether to recall her or not. But still, it's like binary decisions in the initial assessment, and it's a binary assessment to recall or not. You could use other systems like with 5 grades, but at some point you need to decide, should we recall her or not recall her? So there is a binary decision. So that means that, what is required to make you flag a case as potentially malignant might be different from what I require, And if you combine readers, it kind of balances out to some extent. So even if I'm less suspicious than you, we will both review the image, and you will probably find it then. But since we don't allocate readers randomly or in a systematic way, it could be that one exam is assessed by 2 readers, both of which have quite a high threshold for being suspicious, and that means that woman will not get kind of the same level of assessment as another woman might. So AI will, one example is to how to implement AI would be to replace one of the 2 radiologists. Then you have a consistent assessment by AI all the time, but the radiologist might vary a little bit, but it's that variation is kind of made more similar between women because AI is like the same all the time. So that's one way you can implement it, and that's the way we have also examined in a clinical study at St. Göran Hospital in Stockholm to see what is the potential for that and what would it lead to when it comes to cancer detection, but also when it comes to how many cases are moved forward to the consensus discussion, because it is easy to increase the number of cancers detected by just lowering the threshold, but then it becomes not possible to implement it, because if you would recall too many women, there are no radiologists that can handle it. It will cost a lot. Too many women will be worried. So it's important to have the right balance between recalls and cancers detected. So so in that study we compared having 2 radiologists with having 1 radiologist plus AI or having only AI as the initial reader, deciding which cases should be discussed in the consensus discussion. So that's the way we implemented it there. There are other ways. There is another one of the AI companies. They instead they categorize all the exams into 10 categories, where the category 10 is the most suspicious for cancer. And in the studies or the implementations they make, they seem to instead say that category 1 to 7 can be assessed by 1 radiologist, and category 8, 9, 10 should be assessed by 2 radiologists, because it's more likely to contain cancer. I'm not sure which type of implementation is best. But of course, if you do it that way, you save a little bit less radiologist resources, because you will still have 2 radiologists on the top, like 3 categories, around 30% of the exams. But it's a different type of implementation.
It is slightly a reminder of the problems of game theory in terms of how much resources are we willing to put forward in terms of human resources, AI resources, for every patient, with consideration to all patients. But can you make these systems have varying degrees and thresholds on sensitivities for detection?
Yeah, basically you can set it yourself. I mean, they have some kind of recommended or default setting, but when we did this study, we selected the threshold, because we did a retrospective analysis. We used their system on images that we already had, and we knew who got breast cancer or not. And then we calibrated it so that, at least in the retrospective data, the AI plus 1 radiologist would detect 2% more cancer than 2 radiologists. And then we selected that threshold. First, we tried to set the AI to have the same sensitivity as 1 radiologist, because it seemed to us natural that if we want to see if AI can replace a radiologist, we should set the threshold of AI at the same sensitivity as the radiologist. But that didn't really play out well, because then AI makes, like 2 radiologists, they don't make the same assessments. They're a little bit different. But AI and the radiologist is more different. So they flag different cases as potentially suspicious. So if you have the same sensitivity between AI and the radiologist, they together will flag more cases than if you have 2 radiologists with the same threshold, because they are more similar. Maybe they have more the same kind of human background training and so on. So when we tried that, we got too many cases going to the consensus discussion. And then we were thinking, like, what's the purpose here? It's not to have AI and radiologists have the same sensitivity. The purpose is we need to find the same number of cancers when we combine it. So that's why we set it up that way, that we kind of calibrated it in existing data, so that the combination should be slightly better. Like AI plus human should be slightly better than 2 humans.
And in terms of, if we move more towards the detection systems, because AI systems are only as good as the data that you put into them, what are the measures that can be taken? I know you've worked with functional MRIs that are quite on the rise and are very trendy these days. The MRIs, what means measures could be taken to improve the data that is fed to the AI so that it can better detect these cases?
Yeah, so I mean, when it comes to the method of detecting breast cancer, mammography is the one that is the most proven. There have been many randomized studies showing that it's of value. Other common methods that we use, like every day in the department at Karolinska, is ultrasound and MRI, magnetic resonance imaging. Ultrasound is very convenient. You need just a normal office room, basically. There is no radiation, no, just like ultrasound, and you sit with the patient, you hold the probe in your hand. It's easy to take samples if you see something suspicious and so on. But it also takes a lot of time for the radiologist, because you actually have to be there all the time during the whole examination and perform it. But it has a different type of contrast, because it's ultrasound compared to X-ray. So when you have this kind of dense tissue, it's hard to see the contrast between the tumor and the dense tissue on the X-ray, but on ultrasound, it's quite often easier. You get more, there's more of a different contrast. So the tumor is like quite has low echogenicity, means that it looks dark on the image, basically. There's not so many changes in the sound transmission, so that there is not a lot of reflection in the tumor. And we use it a lot, but we don't use it for screening. And also with MRI, we use it a little bit less because it's more expensive, takes a little bit more time, and there are some contraindications. But we use it when we feel that mammography and ultrasound does not maybe tell us the whole truth. So when we need to see more accurate where is the tumor. Could it be slightly larger? Could it actually be more kind of manifestations in the breast? It's not always that it's just in one place. There could be another one. It could be several foci of tumors in one breast, and there could be in the other breast. That's an increased risk for the other breast when you have cancer in one. When it comes to screening, there have been attempts to use, and in some countries they use more ultrasound also for screening. I think some countries where it's more like maybe more available, but also where in general the women have more dense breast, like they have less like fat in the breast, so mammography is a little bit less valuable. Then ultrasound might become a better option. So that could be, but the best is probably, the best relatively common method is MRI, contrast enhanced MRI. So you inject a contrast agent and then you perform an exam, and it might take 10-15 minutes if it's not a very extensive protocol. It's been shown to be definitely the most sensitive of these three methods. So that's something, but it's also it is time consuming. It requires quite expensive equipment, and there's not that many trained staff as for other types of like X-ray examinations. So it would be very difficult or practically impossible to offer it to everybody. So I think the most reasonable thing would be to, as we also trying now that we have developed with the group here at KTH, something like AI algorithms that can help us make the decision when mammography is not sufficient for a specific individual, based on the appearance of the mammogram, to decide that for this woman it is more important to add an MRI or suggest an MRI exam. And that's also an ongoing study, but we only have like preliminary results so far, but it's very, very promising. It's like it's more, we find more cancer than we had kind of thought or imagined that we would. So
it's a system of levels, basically. That's if you qualify, it's not necessarily qualification as some sort of a
in a way. Yeah. So it's and of course there is no clear limit that you have to be above in our scoring system. So it's a trade-off between available resources and how many women do you want to recall without cause to find one cancer and so on. So that's the usual trade-off, and I guess there will also be some health economics aspects when this will be considered to be implemented in routine practice. And I think our results right now are so good that I think that should be done. But we have to finish the study and write it up and do all the analysis, of course. But it looks very promising.
So you mentioned it, and you said it's not necessarily published yet. So I won't necessarily go too deep into it, but just comparing human radiologists and AI, what degrees of precision, statistically, if we look at it, are the differences between humans and AI detections?
Well, I mean, there are a couple of number of different studies, I don't know, maybe 20, 30 studies or so that are decent. And I think it's fair to say that AI seems to be at least at the same level as the radiologist in these studies. So, I mean, how much it can improve, I don't know how much you can improve it. It's hard to say, but I think right now it's like on par with radiologist. But it depends, of course, on how you implement it and if you have validated for certain equipment and a certain setting and so on. Because, I mean, if you have an algorithm that performs very well on images from Siemens equipment, like mammography equipment, maybe you cannot be sure that it works equally well for images that comes from hologic equipment, because it's kind of different image quality and so on. So, but if you use it like it was, that for the purpose it was trained and for the equipment it was trained for and so on, it seems to perform at the same level currently. In some studies you can see that it's a little bit better, and some studies not, like a little bit worse and so on. But so right now I think it kind of hovers around the same performance or accuracy as the radiologist.
So at the current state of it, at least, it's more of a different types of execution rather than necessarily an outperformance of humans, as we see in many other fields of AI.
Yeah, I would say so. I mean, well, yeah, if you compare it heads on, I would say that's true. But then you can implement it in ways that you cannot implement human radiologists. So changing the threshold, for example, to wherever you want it to be is easy to do with an algorithm. But telling a radiologist to become a little bit like, can you please be 10% less suspicious from tomorrow on? It's not easy. So, I mean, it's easier to set the thresholds, to set up a process that, like you can control in a better way. So, for example, you could imagine that you would have an AI system with a very low threshold to filter out cases that extremely rarely would have a cancer. And then that system could handle those cases on its own without any radiologist. But of course, there will at some point be cancer in the group that was filtered out that could potentially have been detected by a radiologist. So, but I think it's like it's probably, if you look at the end result, it's probably a good implementation, but I think it's not possible at the moment to do it because of different things. But I mean, one thing is the medical responsibility that I think right now there has to be a doctor reviewing each image. You can't just let it, let AI handle it. That's one thing, but it's also that it's not. I think it becomes more evident that there are some cancers that are missed in a way. We already miss cancer, but it's not so. It's kind of, maybe I don't know to say if it's more acceptable or so, but I think there is a parallel to like self-driving or autonomous vehicles. Like if a autonomous vehicle hits a person that gets serious injuries or dies, it's less acceptable in some sense than if a person hits a person, because it's I think there is some kind of different standard. You expect machine or the computer to be more kind of perfect in a way. So I think it will take some time before you can accept that maybe this is we will detect more cancers, but we will also miss some cancers that a radiologist would have detected. So I think that is also something that makes it, that kind of implementation difficult. But I think it's probably, if you look at it, it's probably a better way. And that's something that would be very difficult to have a radiologist do, just be extremely suspicious. And I mean, like, you wouldn't save that. So the whole point here would be to save time for the radiologist, because you would not detect more cancer by this, but you would save time for the radiologist that could be dedicated to something else. Or if the management wants to save costs, also to save costs. That's not so exciting, but I mean, that's something as well.
A lot of managers would be excited about that.
But
I think that's I mean, there's a lot of discussions all around Europe about lack of resources in terms of personnel, medical personnel. So if there are systems that can basically automate a large portion of the system so as to give more freedom to the special cases that really need human attention at the current state, at least, is very important. But you think that in the long term there could be completely unsupervised systems?
Like unsupervised in the sense that, like exams that are assessed by AI. Yeah, I think so. I mean, it depends on, like, there must be some kind of public discussion about it and so on, so it's accepted, but it does. I don't think it would be perform worse, necessarily worse than the current system, and obviously it would save resources. So yeah, I guess I would think that could be the case, but I think since I'm like a doctor, I want to help people also. So I don't think you should. I think we need those resources because, for example, the women for which the mammography is not as good method as for the other women, and they would benefit a lot from having an MRI. I think we should put the resources into that, because then we will find a lot more cancers than we miss, and we will find them earlier by MRI compared to mammography or symptomatic detection.
And what do you think, as a doctor who meets patients, is the sentiment of your patients towards, let's say, a half-supervised system or even a fully AI supervised system?
Yeah.
Because, as you mentioned, with self-driving cars, you can have the statistics of it and say self-driving cars are much more safer compared to a driver. But we have this perception, as exactly you said, that computers have to be perfect. So I think the debate for humans accepting these systems is perhaps something that is more complex than developing the systems themselves.
Oh yeah, I mean, well, it's quite different complexities, but I definitely think that it's like a complex question, and probably also that people are not used to it, because right now I think there is not. There are many automated things like that are kind of half automated, that you expect that they work and so on, but these kind of more important medical decisions and cars that can potentially kill someone directly or indirectly, we're not so used to that yet. So I think it's also some kind of there must be some discussion, and there must be more.
A human readjustment of our way of thinking about.
Yeah, I think so. Definitely. But yeah, so and when you said like what do the patients think and so on, there has been some service, and I think it's easy. I don't know, but it seems like if you say, would you like AI and a physician or doctor radiologist to review your image, a lot of people say, yeah, that sounds good, because it sounds like you get a little bit of both, I suppose. But I think we need to have the facts, the data, to support if it's better or the same or worse and so on. And it actually depends on the AI system, it depends on how you set the thresholds, and it depends on a whole lot of things. So right now, I think people just the answer is probably more like a emotional, like it sounds good to have both types of reviewers, but they don't get the facts about how good it is. So I think it's a hard question to give someone. There is not enough information to almost answer it. You can only answer it a little bit in a more emotional way. But what's good is that at least people seem to be quite interested in it, and accepting that AI could do part of the work at least, and that's good.
So it has begun. If we put it like that.
Yeah, and also this study where we use the AI system to kind of suggest which women might benefit from MRI. There is also, of course, sometimes when we find the cancer, because of these algorithms and the study and the MRI. I mean, then you get, of course, very nice feedback and very positive feedback that they had fortune to be part of that. So, I mean, we need to do proper studies and show what happens or what could happen and so on. And then I think the general population will be able to make more informed decisions than today. But I think there is a lot of, I mean, people are excited about it, even not only at KTH, but I mean in general. So yeah.
You mentioned also the question that women from different areas in the world have different types of breasts, and it's something that, especially in the past decade or decades, has come up that the datas that are collected are not necessarily can be used for everyone around the world. You've had participated in a multi-million data gathering project. What measures can be taken to create systems that are not, or at least can minimize data bias?
So, first of all, it's been quite clearly shown that even without AI, there is some bias or some difficulty or whatever it is, so that in the US, where they collect more information about ethnicity so that they know, different population groups better, they see that in some population groups or ethnicities, cancer is detected like a bit later, and the prognosis is then worse and so on. But that's like radiologists, not AI. And when it comes to AI, I think there have been some examples, not in mammography, but otherwise, where you can show that it doesn't work very well for certain population groups. And I guess it might be that it's actually harder to detect something, or it could be that the training data is not representative in a way. It doesn't represent that population group to the same extent as others, so to say. So I think it must be important, I think, to have a balanced data set. And I don't claim to know exactly how to put it together, but I mean, definitely you need to have a lot of examples from a variety of the population where you want to implement it. And what we try to do is we have a collaboration now in Sweden called VIB, Validation of AI for Breast Imaging, which is a collaboration between Stockholm, Linköping and Skåne, the universities there, and regions, the caregivers, and also the Breast Cancer Förbundet, the Breast Cancer Association, the patient organization, they're involved, where we try to set up a platform of cases, women that got breast cancer, women that stayed healthy, and their mammograms, to be able to evaluate different algorithms in the same data set. So it's like, when you want to see how fast someone can run 5,000 meters, you don't ask them to go do your own study. You want them to run on the same track, under the same circumstances. So it's kind of similar here. So we want to have one validation data set and compare all algorithms in that one. And for that validation, we will also include information that is not ethnicity in itself, because we don't really collect it in that way in Sweden, but we will have some information about the geographical, like the birth country will be kind of connected, so that we can analyze not the country, but at least the region in the world where they come from, and see if the AI algorithms might perform worse for some population groups. And we'll also investigate socioeconomic groups and see if there is any difference in the performance depending on that. So yeah, I agree. It's something that has become more important. and especially since it's very hard to, I mean, it's hard to, I mean, AI is a little bit of a black box, so it's hard to really look inside and see these biases. So it's almost like you have to test it. You have to have some kind of validation set where you actually test it, how it performs. So that's what we want to do and want to provide continuously if we can also.
And there is this element, I mean, as someone who's very passionate about technology, that we see how technology is improving people's lives in all places. The access to medical healthcare is not as good as Sweden, because as you mentioned, in Sweden every 2 years there's a mammography for all women between a certain age, but in many places in the world that is in no way whatsoever accessible. Another recent example of that is, for example, Bill Gates through his foundation introduced an ultrasound device that is very mobile. And do you think that AI in breast cancer detection can bring that broader sense to breast cancer detection in a global sense? So that's
I mean, it's so there are many aspects here. So first of all, right now 70% or 75% attend screening, and the other ones, they will not have any benefit from screening because they do not attend. So that's something to work with. That is probably does not involve AI to a large extent, but that is something that could improve the situation even in Sweden, of course. And that is might also be not evenly distributed across income levels and population groups. It might be quite uneven, so that some suffer more than others from that, so to say. And but when it comes to other countries that might have maybe less economic resources, for example, I think ultrasound is it's quite a good method in a way, because you can have very small devices, and I mean, especially they're becoming smaller and smaller all the time, and you can connect it maybe to your smartphone and so on as well. But maybe you want a little bit bigger display to have a good exam. But I've been thinking a long time that it would be nice to have an AI system that makes it possible, because it's also hard to find radiologists in some, I mean, many countries. You don't have that many as here. So I guess I'll turn this off. So then I think it would be good also to have AI to assess the image of ultrasound to see if you find something suspicious in the breast, but also to have AI to guide the image acquisition, because if you have a handheld probe, you can only assess what you see in the images. So it's important to cover the whole area where there could be breast cancer. So I think you need to have both of those AI assisted, like image acquisition and image interpretation. And I think that should be totally feasible. We have not worked with it, but I think, I mean, I'm sure there are others, and I think there are in Lund, Malmö Lund, I think they're also working on that, and I'm sure others as well. So I think that's a very big potential for AI. At the same time, you need to be able to handle what you detect. So you need the whole system afterwards. What do you do then when you detect something? You need to sample it. You need to analyze it. So, you have to put the whole care chain together. But I think the initial part with like diagnostics or detection, AI can help a lot there. And combined with mainly ultrasound, I think, because it's portable, it's easy to move around. There's no radiation. It's potentially a little bit, I mean, cheaper also to buy it and so on. Yeah.
So there is this prospect of at least improving detection very much. The sad part of that is that the resources for taking action on that detection still are a bit further away in poorer countries with lower economic resources. But you mentioned also that in Sweden, there is no gathering about people's ethnicity.
Mm-hmm.
And to a certain degree, I think that is because of the freedom of speech rules in here. But do you think, as a doctor, that those should be increased? Or
Well, I mean,
it's a very ethical question,
it is.
but
I don't know. I mean, the only as a doctor, I don't know. You know, it's not very necessary. But as a researcher, and if you want to validate AI algorithms, I think it's necessary to have that type of information. But if the way to collect it or that how you do, I have no strong opinion on that. But I think, I mean, we would not want to miss that an AI might be really bad for certain group of people. I mean, that would be very important to uncover. And the problem, I guess, with AI is that you cannot just look inside and see, oh, it prioritizes this group of people, but it's not, because that's not the way it works. It has just been shown a huge number of examples from one group that might have certain characteristics and not so many examples from another group. And then it might not perform very well for that group, or it does. But I mean, it's not known, so I think you really have to test it. We don't necessarily have to test it in Sweden, I suppose, unless we, but it should be tested. And but of course, it's also, I mean, when you collect that information and so on, this is not the only consideration that you have to make, but from a pure like AI validation perspective, it would be good to have.
Yeah, and it is. I mean, you've probably heard about the ChatGPT and how it became from the previous models so stronger compared to the previous models. Is that there's so many people just walking and trying to detect those biases that it might have developed based on the corpuses that it was trained on.
Yeah.
So even maybe in Sweden, it wouldn't be too bad of an idea to go through the data, which is a very hard and time-consuming thing to do, but it improves the results quite significantly.
Yeah, I mean, I think it's a good idea from the research perspective, and for the use for patients, of course. Since we've seen that it can happen that there is that kind of bias, we have already seen it, so I think it's important to assess it and to know about it.
And if we move to the more long-term impacts of AI in not just mammography, but in the healthcare sector, do you think that the biggest impact will be that of a better allocation of resources?
I hope not. I mean, I hope we will be able to kind of extract information that we do not extract today. And I think right now we're still, well, maybe we're bordering, but I mean, we're still kind of trying to mimic a human professional. So we make AI systems for radiology, and we make an AI system for pathology, and we might make an AI system for genetics. And I think we're missing out on a big opportunity, and I guess people are aware, but this is the convenient, easy way to develop algorithms right now. But I think the reason why we have these medical specialties is because of human limitations. So we have radiologists, but we also have breast radiologists because it's too hard to be equally good at all radiology on a higher level. It's better to narrow down on breast imaging, and then you become good enough. And then, but you're not good at pathology, so then you need a pathologist, and maybe a pathologist that is also specialized in breast pathology and so on. But I mean, that's mainly due to limitations of human beings, like the brain and so on, that one human being can master this type of area with its width and depth and so on. So I think, and I hope, and then the way, I mean, we have connected humans, I guess, in a much better way than animals are connected, because they don't have the same like language as we have, some like advanced language. So I think we have now a connected network of humans because of our language, but it's also not conveying all the information. So when one pathologist tries to tell a radiologist what she has found in the image, the pathology image, the slide, like the sample, they look at tissue, like microscopic slides. They have to simplify. They have to categorize. They have to simplify what they say, because they have to transfer it to someone that is not as like knowledgeable as they are. So you have to simplify the information, and then the radiologist have to simplify the information, and then you use this simplified information to make a decision. But that's I don't think that's because the limitations of the human mind. And then for AI, there is no such limitation. So there's really no reason why there shouldn't be possible to have like one AI system doing all you need for, at least for a certain disease or for certain, whatever you want to do. But let's say breast cancer, to have to be trained on all the raw data that from all the diagnostic fields, like genomics, pathology, radiology, whatever, and then make like decisions or suggest decisions based on analyzing the data without simplifications.
That's a very interesting prospect to think about, because there is a big divide in the AI community about more specific and directed approaches to more general approaches. And those who are slightly more of the romantic type of feelings, like the more general systems that will be capable of doing very many great tasks, and of course they lead to very many great benefits for humanity as well. But in the long term, as a final question, what are you looking forward to in your field, with consideration to all technologies, not just necessarily perhaps AI, but what is the breakthroughs that you're looking forward to?
Well, I'm kind of thinking within my field, I guess, a bit. So, I mean, the best thing would, of course, be to detect like all cancer before it has like metastasized. I think that would be really good. And on top of that, it would be good, of course, also to try to prevent the cancer from even starting.
What are your thoughts, as one more last question, on the mRNA type of combating cancers that are now being developed?
Yeah, I'm not. I don't.
They are at a very preliminary stage, and but it's a very, I think, ambitious but also exciting, perhaps, prospect.
Yeah. I don't. It's not my area really of expertise, but there is a lot of. I mean, exciting treatments and diagnostics and so on. So it's. I think it will be. I think a lot of things will happen and develop. I mean, the next 5 to 10 years. So I'm very excited to be kind of part of it, and also to see what others are doing, and of course, in the end, we just want to see that it helps the patients and helps the persons and so on. So, yeah, that's what I'm looking forward to.
That's very beautiful. But Fredrik Strand, thank you very much for participating in the podcast.
Yeah, thank you. It was a pleasure.